Hello, guys. Can you hear me? Can someone confirm you can hear me?
Yes. Yes, you can.
Okay. Welcome to today's CME session. My name is Fatuma Jama, and I'm BCHP 5 student at the University of Nairobi. So today, before we begin, I'd like to introduce XYZZEMed. XYZZEMed is a dynamic community of medical students from different universities committed to transforming medical education in Kenya. This initiative focuses on creating accessible, locally relevant, and contextualized resources that address the unique healthcare challenges of the region. The aim is to revolutionize medical studies and enhance understanding of various topics while maintaining an inclusive, engaging environment. We hope to encourage curiosity, collaboration, and critical thinking among future healthcare professionals. So today's CME topic is on epidemiology. The topic is measures of disease association. Now I'd like to introduce our speaker for the day. The speaker is Samito Kibet Jr., a 50-year MBCHP student with a keen interest in medical research, particularly in the fields of cardiology and surgery. Outside the lecture halls and wards, he enjoys gaming as a way of unwinding. He lives by the mantra, Christ paid it all. Samito, welcome.
Thank you for the introduction. Can you guys hear me clearly?
Yes, I can hear you. We can hear you.
Okay. So in case I break or anything, kindly just
Sure.
inform me. So today's session, we will be looking at measures of disease association together with tests of validity. So can you see my screen? Can you see my screen?
Yes, we can see your screen. Sure.
Okay. So let's start. It's going to be a bit intensive in terms of doing calculations and all, but I pray that you may follow through. So basically our objectives for today is we're going to look at two things. One is measures of disease association, where we have relative measures and we have absolute measures. And the next, we're going to look at tests of validity. So test of validity, this basically pertains to screening, testing the accuracy of a screening tool. And the tests that are usually used, basically we have sensitivity, specificity, positive predictive value, and negative predictive value. I think I'll start the disclaimer. Not that I've understood everything in this topic. I just some concept I struggled with, but we learn all through. So basically, epidemiology by definition it has a long definition, but there's a simple one that I usually remember is a study of what is upon the people. And basically we are talking about problems or basically of public health importance. Yeah, and the reason of the goal of epidemiology is come up with interventions that deal with those problems. And the key to coming up with interventions that deal with those particular problems is comparison and finding associations mainly between exposure and outcome. If you look at disease or health outcomes, basically. So disease, death, even getting better. Yeah, so the key is comparison and finding association. That's why it's important for us to know these measures of association. So think of two situations. The first one is you observe a higher incidence rate of a disease. in a specific population compared to other populations. So, for example, we start with maybe sickle cell, anemia, or the sickle cell gene. You find that it is more prevalent in a specific kind of population or a particular population compared to another population. And you need to ask yourself, why? Why is this so? Is there something that this population is being exposed to that is different from this other population? So trying to find an association between these two, that's where these measures of association come about. Another one is have a group of patients who become sick after eating from a certain vendor or a certain restaurant. And the question that you need to ask yourself is that, are these two related? Is that the restaurant is just popular and many people go to eat there, including the patients, or is it related to the outcome, which is the patient's disease? So basically, that's the foundation. And measures of association, by definition, it quantifies the relationship between an exposure and an outcome. And an exposure can be anything. It is not limited to, let me call them environmental hazards. It's not limited to maybe poor sanitation or radiation or whatever, but it is all inclusive. You know, it is a term that is used loosely and it can refer to very many things. So we can have inherent characteristics such as age, sex, race, even ethnicity. We have some acquired characteristic, marital status, education, biologic, which can be the immune status of the patient, the condition one lives in, so the socioeconomic status, we're talking about water and sanitation, we're talking about food security and all that. So it can be a range of things, very many things. Okay, even it can be exposure to treatment, to a certain treatment. So yeah, an outcome, by definition, these are health outcomes. We're talking about the disease, death, or healing, or recovery, basically. Let me say that. So under measures of association, you have the relative measures, and we have the absolute measures. Relative measures basically assesses relative measures assesses how many times more a disease is in one group compared to another. And most of the times it's how many times more a disease is in the exposed group compared to the unexposed group. Okay? Then, so basically there we're dividing, we're finding ratios. And absolute measure, this is how much greater a disease is in one group compared to another. And here we are minusing. Okay? And they have different importance. So relative measures, we have two types. We have more than two types. We have other ones, but I just use the ones that you are taught class, where we have relative risk, also known as risk ratio. And then we have rate ratio. So relative risk, also known as risk ratio, and we have relative ratio. So the difference between the two is in relative risk or in risk ratio, we are using cumulative incidence, which is also known as incidence proportion or attack rate. But in rate ratio, we're using incident rates. So the difference between cumulative incidence and incidence rate, this is another topic known as measures of disease frequency. But just the short of it is that cumulative incidence is basically, let's say, at the beginning of this year, we have 100 people, okay? Then at the end of the year, we have 20 people developing a disease from that group, okay? So the cumulative incidence is basically 20 over 100. So yeah, basically the frequency of occurrence of new diseases in a population. But incidence rate usually accounts for follow-up, okay? So let's say you are following up people for a period of 5 years and you start with 10 people in the first year. But in the second, third, maybe you lose some people to follow. And by the time you're finishing, you have, let's say, 7 people. So what incident rate accounts for is that loss to follow-up. And what you're going to divide is the number of people who develop a disease over what we call person years. Okay, so let's say um, you lost one person at 2 years. Okay, so then you had 7 completing the 5 years. So you're going to take 7 times 5. I think so. Something like that. But basically, the difference is that incident rate accounts for follow-up. So relative risk, as I've said, it compares the risk of a health event in one group compared to another. But rate ratio compares incidence rates, or what we call person time rates of 2 groups. So we're going to talk about the 2x2 table, but the 2x2 table is what really helps me understand these concepts in epidemiology. And we're going just to go through it quickly. So as you said, basically you're measuring exposure and outcome. So exposure is on this axis over here, and we have exposed and not exposed. Then you have disease and no disease. So basically, A is those ones who are exposed and had the disease. B is those who are exposed and didn't have the disease. C, they were not exposed but they developed disease. And D is that they were exposed and they didn't. They were not exposed and they didn't develop disease. So that's basically the 2x2 table. We talk about measures of association. So we have A, B, C, and D. Okay. So how do you get relative risk, or how do you calculate relative risk? So basically, relative risk is the risk of developing the disease in the exposed over the risk of developing the disease in the unexposed. So if you look at the exposed over here, those who are exposed, the total number is A plus B. Sorry, these have been mislabeled, sorry. But A plus B is the total exposed, okay? So among A plus B, which is the total number of people who are exposed, it's only A who developed the disease. So the risk of developing the disease in the exposed, it is A over A plus B, as stipulated there. What about the risk of developing the disease in the unexposed? So those who are unexposed are C plus D, okay? And only C developed the disease. So C over C plus D equals to the risk of developing the disease in the unexposed. So, as you said earlier, that relative risk or risk ratio is risk of developing the disease in the exposed over the unexposed. So we're going to take these two and divide them. So A over A plus B divided by C over C plus D. And that is how you get your relative risk. So important things to remember is you first calculate the risk of developing the disease in the exposed over the risk of developing the disease in the unexposed. Okay. So basically an example here that we're going to look at is that there's I just found this question online. In an outbreak of tuberculosis among prison inmates in South Carolina in 1999, 28 of 157 inmates are residing in the East Wing and they developed tuberculosis. Okay. In the West Wing, we had only 4 out of 137 who developed tuberculosis. So if you're going to develop or come up with a 2x2 table, remember your exposure is either going to be East Wing or West Wing. Okay, that's exposure. So we are thinking that being in the East Wing, you're being exposed, okay? But in the West Wing, it's unexposed. Then TB and not TB, okay? So as you say that those who are in the East Wing and developed disease were 28, while the total was 157. So those who didn't were 29. Then the West Wing, those who developed were 4, and the total was 137. So those who didn't were 133. So the risk of developing the disease in the exposed will be 28 over the total, which is 157, which gives you 0.178. Then you have 4 divided by 137. That is the risk in the unexposed, which is 0.029. Okay, so the relative risk or the risk ratio is dividing these two values. So the risk in the unexposed, in the exposed, and the risk in the unexposed. Therefore, you get a total of 6.1. You get a value of 6.1 as your relative risk. Okay, so there's a way that you can interpret this. Once you have your relative risk, how do you interpret it? Is that if the relative risk is 1, that means that the risk of developing the disease in the exposed and in the unexposed is similar. So basically, it doesn't mean much. So there's identical risk in both groups. Okay, but if it's greater than 1, that means that your numerator, which has the risk of the exposed, is greater than your denominator. So there's an increased risk of developing the disease with exposure. Okay, but if it's lesser than 1, that means that your numerator is smaller than your denominator. So that means that there's a decreased risk of developing the disease with exposure to whatever. So, and you can also say that it's somehow protective, that when you are exposed to that particular thing, you have a lesser risk of developing the disease. So it's somehow protective. So if we go back to our case right here, we found that it's 6.1, so it's greater than 1, meaning that there is higher risk of developing the disease or developing TB when you're in the east wing compared to the west wing. Okay, but now another way we can interpret it is we want to say by how much more. So what you do is you minus 1, so 6.1 minus 1, you get 5.1, then you convert it into a percentage by multiplying it by 100. So then your concluding statement is that there is a 510% higher risk of developing TB in the east wing than in the west wing. Okay, so that's relative risk. Risk ratio, basically you use incidence rate, and to calculate incidence rate is a bit complex. So if you really want to know more about rate ratio, maybe if the question comes with incidence rates already, but to calculate incidence rates is a bit tricky, a bit complex compared to cumulative incidence. But basically it's the same thing, but you're using incidence rates. So those are relative measures. So we talked about relative risk and or risk ratio and rate ratio. And absolute measures, we also have we have risk difference and rate difference. So risk difference, again, we're using cumulative incidence or incidence proportion, while rate difference, we're using incidence rate. And you say that in absolute measures, we are subtracting, okay? Because we want to know how much more, not how many times, okay? So again, your 2x2 table, and it's basically the same. So the risk in the exposed, which is A over A plus B, which is the total of the risk of developing the disease in the unexposed, which is C over C plus D. So the risk difference becomes the risk in the exposed minus the risk in the unexposed. That is your risk difference. Okay. So it's basically that simple. So what's the importance of risk difference? Basically, risk difference is also known as attributable risk. Okay? And from the word attribute, that we can say that this number of people or this number of cases is attributed to to a certain exposure. Or basically, attributable risk says that the disease burden is specifically in the exposed is associated with exposure, meaning that if we were to eliminate the exposure, and here we are assuming causality, meaning that we are assuming that the exposure is leading to the disease or the outcome. So if we eliminate the exposure, that this is the number of cases that are going to be eliminated. That is why it's known as attributable risk or risk difference. And if you actually think of it, you're taking the risk in the exposed minus the risk in the unexposed. So the risk of developing the disease in the exposed, okay? And we say that that is A over the total, meaning that A plus B were exposed, but it's only A who developed the disease, okay? But again, we are accounting for those unexposed who developed the disease, which is C over C plus D. Okay, so if we minus the two, we remain with a figure that is attributed to exposure, and that is what we call risk difference or attributable risk. Again, meaning that if we are assuming causality, that means that exposure is leading to the outcome. If we prevent or if we eliminate the exposure, the risk difference is the number of cases that will be eliminated. Okay. Yeah. Most of the time uh, whatever presented as a percentage. Okay. But yeah, so we just use this similar case over here. And our risk, remember, in the exposed is 0.178 and in the unexposed is 0.029. So if we minus the two, we have a risk difference of 0.149. If we convert it to a percentage, it is 14.9%. And how do we interpret that 14.9%? We say that assuming causality, assuming that being in the east wing, in the east wing leads to TB, that if we remove the east wing, we are going to eliminate 14.9% of the cases of TB in that dormitory. That's basically what risk difference or attributable risk means. Okay. So from that, we go to another concept of population attributable risk. So remember that these basically we think of it as a sample, but it's basically not representative of the whole population. But what if we want to calculate the population attributable risk or the population risk difference for the whole population? Now, what do we do? Okay, so we can calculate it in two ways. First of all, is that we can get the risk of the disease in the total population minus risk of the disease in the unexposed. Okay. So let's say, for example, just an arbitrary figure that the total population, let's say, is 1 million, and in the 1 million, those who are exposed are 700,000. Okay? 700,000. And among those who exposed 700,000, 500,000 develop the disease. So your risk in the total population is 500,000 over the total who are exposed, which is 700,000. So that is basically 5 over 7. Okay. Then the risk in the unexposed is that the remaining 300,000 who are not exposed, let's say 100,000 develop the disease. So your risk in the unexposed is 1/3. Okay. So if you take 5 over 7 minus 1/3, just 5 divided by 7 minus 1/3. You get a value of 0.38 or 381. Okay, if you convert it to a percentage times 100, you have 38%. So what you're saying is that if we eliminate the exposure, the number of cases that you're going to eliminate is 38%. So basically that is population attributable risk, okay? But what if you don't have the risk in the risk of getting the disease in the total population? We can get it from the risk difference, basically. So from the risk difference, what you do is you multiply it by the proportion of the population that is exposed. Okay, proportion of the population that is exposed. So basically, if you, let's say, again, use an example, we have a population of 1 million and it's 700 who have been exposed. So that is 700 over 1 million. That's our proportion. So that's 7 over 10. Then you calculate the risk difference and multiply it by 7 over 10. Therefore, getting your population attributable risk or population risk difference. So we can use here, we can use this example to go through it. So Over here, you have a scenario that suppose in a population you have 10,000 individuals and 30% are exposed to a certain risk factor. Okay. So the risk of disease in the exposed group is 0.2, which is 20%, and the risk in the unexposed is 0.05. Okay. Remember that if we don't have the risk of getting the disease in the whole population, we use population attributable risk, or population risk difference is equals to the risk difference and the proportion of the exposed in the population. So our risk difference over here is equals to the risk in the exposed minus the risk in the unexposed, as you see down here, which is 0.15. So that's our risk difference. Then we multiply it by 30%. 30%, that's basically 0.3. Getting a figure of 0.045. So that's your population risk difference, 0.045. And now, how do we interpret it? Meaning, convert it into a percentage. That's 4.5%. Okay. So 4.5% of the total population's disease can be attributed to the exposure. Remember, attributable risk. What does this mean? Is that if we are to intervene and remove the exposure, we are going to eliminate 4.5% of the total population's disease. So that's basically it. Another one is odds ratio. Odds ratio, so basically when we talk about odds, is we are talking about the probability of an event occurring over the probability of an event not occurring. So the probability of the event over the non-event. So that's basically odds ratio. So odds. So when you talk about odds ratio, it's going to be odds of the disease in the exposed over odds of getting the disease in the unexposed. And if you look at it, if you look keenly, it's quite different than risk ratio. Okay, because if you're going to calculate the odds of the disease in the exposed, we have said that it's odds of the event over the non-event. So the total number of the people who are exposed are A and B. Okay, and among those who are exposed, A developed the disease while B didn't develop the disease. So the odds of getting the disease in the exposed is A over B, the event over the non-event. Okay, same to the not exposed group. In the not exposed group, C developed the disease, D didn't. So the odds of developing the disease in the unexposed group is C over D, event over an event. Again, because it's a ratio, you're going to divide the two. When you divide A over B divided by C over D, remember we can cross multiply such that it's A times D over B times C. So A times D over B times C. So basically that's how we calculate odds ratio. It's different from relative risk. And just a simple question, and maybe someone can quickly respond. Why is this the method of choice in case control studies? Why do you think that this is the method of choice in case control, while relative risk is the measure of choice in the cohort studies? Who can someone you can just quickly unmute and answer it? Why is odds ratio basing on what we have learned? If you compare odds ratio and relative risk, why is odds ratio the method of choice when you're dealing in case control studies, while risk ratio, relative risk, is in cohort studies? Anyone?
I can give it a shot.
Yeah,
I think it's because of how you identify participants in a case control study. You identify them based on outcome status. So that means you can't calculate the risk of someone developing an outcome if your criteria for identifying people is people who have that outcome already.
Yeah, so that's basically it. It's hard for you to calculate incidence in a case control study because you start with the disease already, not the outcome. No, not the exposure. You start with the outcome already. So it's better to use odds ratio in a case control because it's hard for you to calculate incidence in case control, but in cohort you can calculate incidence because you start with an exposure, then you follow it to an outcome. So you can get both cumulative incidence and incidence rate. So if we are going to an example of odds ratio, so this I have no question, but just the 2x2 table. We have A, so the exposed, among the exposed were 2,100 developed the disease, 1,900 didn't. Among the not exposed, 80 developed the disease, 7920 didn't develop the disease. So what's the odds ratio? Remember, it's A times D over B times C. So 100 times 7920 over 80 times 1900. And that gives you 5.2. So how do you interpret it? Again, 5.2, we interpret it similar to what's it called? Risk ratio or relative risk. So what you're saying is that if it's 1, meaning that there's an identical risk. If it's greater than 1, meaning that the risk of developing or the odds of developing, the odds of developing the disease in the exposed is higher compared to the unexposed. If it's less than 1, it's protective, or the odds are smaller compared to the unexposed. But how we interpret it is how many times higher. So we minus 1, multiply, convert it to a percentage, which is 420%. And then your interpretation is that there's a 420% higher risk of developing the disease in the exposed compared to the unexposed. So just a quick one from this 2x2 table, can we calculate the relative risk? What's the relative risk? Then you compare the relative risk in the odds ratio. We can quickly calculate, then someone who has the answer can just say it. Yeah, 5. Okay. So 5 is the relative risk. Okay. So again, if I interpret it, it is 5 times. So that means that there's a 5 times increased risk of developing the disease in the exposed compared to the unexposed, but there's a 400% higher risk of developing the disease in the exposed compared to the unexposed. Okay, so you can see that risk and odds ratio, the relative risk and the odds ratio, they are almost the same. Okay, so that's why in case control, our odds ratio can be used as a risk ratio, especially when the disease is so rare. You can use it as a risk ratio, because from this example, you can see that they're almost similar. Okay, so we are done with measures of association. We have looked at the relative measures where we talked about specifically and in depth the relative risk and the risk ratio, but we also mentioned about the rate ratio, which uses incidence rate. We also looked at absolute measures where we talked about risk difference and rate difference, which uses incidence rate. We also talked about the population attributable risk, and we said that the risk difference is also the attributable risk. So quickly we'll move to tests of validity. In the next 10 minutes, 15 will be done. So in tests of validity, we're going to look at sensitivity, specificity, positive predictive value, and negative predictive value. So Basically, this is for screening. You know, screening is you're trying to identify the disease when it is in its preclinical phase. So basically, when it's during its early stages, okay, so that you can diagnose it early and treat it early for better outcomes. But again, we know that you have both positive and negative consequences, because the positive consequences is that you're going to be able to treat it, diagnose and treat it early and whatnot. But again, the negative consequences, for example, for the false positive, is that we're going to miss a number no, we're going to diagnose uh, basically anxiety. So people who don't have the disease as being declared having the disease from the screening test. The false negatives are going to miss some people who have the disease and all that. So, but screening is really important for early detection. And again, there are some appropriate diseases for screening. There are some there are various characteristics that determine an appropriate disease for screening. Okay, so things like I think it's a long clinical phase and whatnot. You can just go and look more into that. But now for a screening test, there are various things that assess its I don't know the term to use there, but a screening test must be accurate, meaning that it must be valid, it must be reliable, precise, it must be safe and acceptable, it must be simple and cheap, and so many other things. So for accuracy, meaning that for example, if you use this image on your right, an accurate one, if the center is our bullseye and that's what we're targeting, okay? If we start with over here, you can see that it misses the bullseye. And apart from it missing, it hits several places, okay? So that's basically low accuracy and low precision. From here, it misses the bullseye and hits somewhere close to the outer circle, okay? And this, remember our target is the bullseye, okay? So if we get the bullseye, that's an accurate result. If we miss it, that's not accurate. But you can see that this here has high precision, and high precision, basically reliable, is that if you repeat the test, it will give you similar values, okay? But a test can be precise and not accurate. A test can also be accurate and fail to be precise, okay? So, for example, as you can see over here, is we get the bullseye twice, yeah, and maybe these other two, but we miss it on a number of occasions. Okay, meaning that yes, we have high accuracy, but our precision is not good. The best test is one that has high accuracy and high precision, meaning that it will give you the correct result, and when you repeat the test again, it will give you similar results. Okay, so that's accuracy and reliability and precision. But now we are talking about measures of validity, measures of accuracy. And basically, a 2x2 table is your go-to. Whenever you have this question, either picture it in your mind or you just do it. So a 2x2 table for a screening test. So you're going to have the screening test, then you're going to have the disease status, either what is in the population, or we are going to use a gold standard test, okay? So for the screening test can either be positive or negative. For your disease status, it can either be yes or no, okay? You either have the disease or you don't, okay? And this is from either from population figures or the gold standard test. So if you get a positive value from your screening test and you do have the disease, those are your true positives. If you get positive but you don't have the disease, those are your false positive. If you get your negative and you have the disease, that means that it's a false negative. And if you get a negative result and you don't have the disease, that's a true negative. Okay. So what is sensitivity then? So sensitivity, by definition, is how well a test classifies people with the disease as sick. Okay, so people with the disease, if you look at your 2x2 table, people who have the disease are A and C from the gold standard. Okay, but the screening test can only identify A. So the sensitivity of a test measures how well a screening test, or basically a test, can classify people with the disease A and C as being sick. Okay, or basically another definition is that it is the percentage of people with the disease who test positive. The people, I repeat, the people who have the disease are A plus C. Those who test positive are A. So the percentage of people who test with the disease who test positive in the screening test is A plus C. Okay? No, yeah, it's A over A plus C. So basically sensitivity then is your true positive over all the people with the disease. And all the people with the disease is A plus C, and your true positive is A. Then you multiply it by 100. So if you have a test that has a very high sensitivity, let's say of 95%, that means that this screening test can correctly identify 95% of people as having the disease, okay? But it will miss on 5% who have the disease, okay? So that's sensitivity. Specificity, on the other hand, okay, is how well a test classifies people without the disease as being healthy. Or basically, it's the percentage of people without the disease who test negative. The people without the disease, according to the gold standard, or what is in the population, is B plus D. Okay, and those who test negative in the screening test are only D. So D over B plus D times 100, that gives you a specificity. So again, if you have a test that has a specificity of, let's say, 90%, that means that it correctly identifies 90% of people as not having the disease, but it will fail to identify 10% of people. Okay, so it will falsely identify 10% of people as having the disease, yet they don't have the disease. So specificity is highly dependent on false positives, okay? And this is what we really want to, if the thing that we really want to avoid in a screening test are your false positives and your false negatives. Because false positive, again, as I said, you're going to give people anxiety. Okay, you're telling them that you do have the disease, but in reality they don't. Okay, they end up spending more money to diagnose. Okay, and all that. Okay, and for your false negative is that you falsely identify people as having the disease as negative. So let's say it's an infectious disease, and you release them from a screening, and you release these people back to the population. So there's that probability of them again going to spread the disease and all that. Okay, so yeah. So there's a relationship between sensitivity and specificity of a test, because a test has to maximize on both. Okay, and for you to identify whatever the relationship you use, what you call a ROC, ROC. Think in full, it's receiver of characteristics or something. I'm not quite sure. So again, if you want to go and look at what it entails, feel free to do so. So the next one is positive predictive value. Positive predictive value can be defined in very many ways. So let's look at them. So the first one is how likely it is that a positive test indicates the presence of disease. So if you look at the screening, the positive results from the screening test, both were, the total number was A plus D, okay? So what is the likelihood that a positive test is going to indicate presence of disease? That is positive predictive value, okay? So if you calculate positive predictive value, you take your true positives over all those who test positive, so A plus B, okay? Another way you can define it is that the probability that an individual has a disease given that they test positive, okay? Or the probability of a positive test to indicate it's okay. Another way is that it's the percentage of all people who test positive. Percentage of all people who test positive and who really have the disease. So it can be defined in very many ways, but basically we are looking at the true positives over the total number of positives. So A over A plus B times 100. So this positive predictive value is influenced more by specificity than sensitivity. And why do we say so? Because specificity, as you said in the previous one, it determines your false positive. Okay, it determines your false positive. So if we have, let's say, our true positives are 90 and our false positives are 10, the positive predictive value over there is going to be 90 over 100, which is 90%. Okay, but see what happens if your false positive increases. That is, now you have your true positives being 90 and your false positive being 20. So that is 90 over 110. So 90 over 110 is 81%, 82%. So you can see that if we have an increase in the false positives, or if you have a decrease in the false positive, it's going to affect your positive predictive value. I'm not saying that sensitivity won't affect your positive predictive value. It will affect your positive predictive value, but what affects it more is your specificity, okay? Your specificity. So, lastly, negative predictive value. Negative predictive value is how likely a negative result indicates absence of disease, okay? The probability that an individual doesn't have a disease, even though they test negative, or the probability of a negative test indicating absence of disease, okay? So how do you calculate it? It is the total negatives is C plus D. Those who don't have the disease are D. So D over C plus D times 100. And that is a negative predictive value. So those are the four measures, basically your sensitivity, specificity, positive predictive value, and negative predictive value. So these are, we can do this example, then we'll end the session there. So a new screening test is developed to detect malnutrition in children under 5. And for us to evaluate its validity, 200 children are screened. Okay. And then the results were compared to a gold standard. So basically the gold standard can be WAG or whatever. Okay. So those who tested positive in our screening test were 50. Those who tested and actually malnourished were 50. So these are true positives. Our false positives are 20. False negatives are 10. The true negatives are 120. So the first question, what is the sensitivity of our test? You can, what's the sensitivity of our test?
I'm getting 0.7.
No, it's not 0.7. Yeah, it's 83.3%. As I said, sensitivity,
I have
remember,
71.4.
okay. So the answer is 83.3%, and we'll see why. As you say that sensitivity is how well test classifies people with disease as sick, basically. Okay. What you do is those who have the disease, who are malnourished, according to the gold standard, the total number is 60. Okay. But our test can only identify 50. Okay, it's not able to identify this 10. So the sensitivity of our test is, if this is our A and this is our C, it's usually A over A plus C. So 50 over 60, convert it into a percentage. That is our sensitivity. I'll take you back to the table that was there earlier. Remember that the percentage of people with disease who test positive. So remember, those who have the disease, the total number is A plus C, but our test can only identify A. So A over A plus C times 100, that is our sensitivity. True positives over all with, sorry, all with disease. So in our case here, it's 50 over 60. What about specificity? What's the specificity of our test? It's not 14.3. What's the specificity of our test? 85. I'm getting 80. Any other choice? It's close to 85.5 basically. 85.7. 85.7. Again, specificity, how well it classifies people without the disease as healthy. So basically, the percentage of people who are not malnourished and test negative. So the people who are not malnourished, the total number is 140. But our test can only identify 120. So 120 over 140, that is our specificity converted to percentage. Okay. Then the next one, calculate our positive predictive value. What's our positive predictive value? Yeah, 71.4. So 71.4. So remember, it's among those who tested positive, how many are malnourished? So those who tested positive, the total is 70. Those who are malnourished, 50. So 50 over 70 is our positive predictive value, most affected by our false positive, okay, or specificity. Our negative predictive value, on the other hand, is what's our negative predictive value? Yeah, 92.3. So among those who tested negative, how many are not malnourished? So the true negatives over all those who tested negative. So 120 over 130, giving us a value of 92.3. So based on this value, our sensitivity, our specificity, and our negative predictive value, do you think that our screening test is something that you can use to go and screen for malnutrition in a rural area? Yes or no? And if yes, give reasons why. If no, give reasons why. the response based on the values that you have above. You think that our test is something that you can use to screen for malnutrition? Okay, I think I can leave that for us to think. Okay, so basically, based how do we determine if a test now based on our values? Okay, how can we know that this test is good for us? But basically, for our screening test, it had a specificity sensitivity of 83%, meaning that it's going to correctly identify 83% of the people who are malnourished, okay, and fail to identify 17. Among those who are not malnourished, it's going to correctly identify 85.7% as those who are not malnourished, okay. It has a low positive predictive value. It has a low, that's 71.4%, meaning that the likelihood of a positive test to indicate someone as being malnourished is 71.4%, which is a bit low, but considering that it can correctly identify 3% as being malnourished, okay, if you look at its negative predictive value, which is 92.3%, meaning that the probability of a negative test indicating that someone is not malnourished is 92%. Those values are quite high for something that probably you can consider to use to assess for, to screen for malnutrition, not assess, screen. So thank you for paying attention. That's all.
Thank you, Samito, for this really informative session. Now we'll move on to, does anyone have a question, comment, anything? You can unmute or leave it in the chat box. But now we'll move on to the Kahoot session. You can open Kahoot and enter the game pin that will be displayed there, or scan the code that will be displayed. So yeah, go to www.kahoot.it and enter the game pin. Shensia is in. In the meantime, Samito, there's a question in the chat box you could answer. What percentage of sensitivity will be considered good for the screening test?
So for what percentage of sensitivity? Obviously, the ideal is that the higher it is, the better it is. Okay, the higher the sensitivity, the better it is. But it's not often will you find that we have both high sensitivity and high specificity, or high sensitivity and also the predictive values are quite high. Okay, that's why we need the ROC curve. So the ROC curve is what helps us to determine the cutoff point, okay, between our specificity and our sensitivity of a test. Yeah, that's what I can say. So if you really want to know, I think you can just go look at the ROC account. ROC.
Thank you. Oh, Valentine says the session was quite informative and made it easy to understand. Oh, okay. Her question has been answered. Okay, guys, join. So someone is asking where they can find the recording. I think XYZ, it will be uploaded on XYZ platform. You're welcome, Faisal. Okay, we have 7 people in. We can start. Okay, remember the faster you answer, the more points you get if it's correct. So what measures of disease association is used in case control studies? Time is up. So 6 people got that. It was odds ratio. Let's move on and see who's leading. CH is leading. Oh, CT0 Palace 3 is next. Let's move on. A risk ratio of 2 suggests ten seconds to go. Okay, almost everyone got that. The exposed group has twice the risk of outcome. CH. The symbol is back. Which measure is appropriate for cohort studies? Five seconds to go. Risk ratio. Almost everyone got that. The symbol is leading. Sensitivity measures a test ability to yes, everyone got that. Correctly identify those with disease. Okay, the symbol is still leading. A high specificity test is most useful when so avoiding false positive is crucial. Everyone got that. Nice. Let's move on. If a test has a high positive rate, which metric is likely low? Okay, now here there's a tie between everyone. So it's specificity. The symbol is still leading. positive predictive value tells you? The chance that having the disease, the chance of having the disease if the test is positive. Yes. Okay, Shense is coming up. If a test has 95% sensitivity and 90% specificity, what happens if the positive predictive value? What happens to the positive predictive value if the disease prevalence decreases? It decreases. In a study, 80 out of 100 people test positive. 90 out of 100 healthy people test negative. What is the specificity? Yes, 90%. 2 people got that right. Oh, Shense is in the lead. A test with 95% sensitivity means? Yeah, it misses 5% of true cases. Many people missed this. RSM number 3. Second place, we have that symbol. And in first place, we have Shansea. So Shansea, could you unmute maybe and tell us who you are and how you found the session today?
Hi, I'm Shensa. Yeah, the session was amazing and I learned a lot. Thank you.
Thank you. And this symbol, I really want to know what this is. This Greek thing. So congratulations, guys. Thank you for joining the session today. I hope you learned a lot and see you next week.